Welcome everyone to today's webinar. My name is Rebecca On, and as today's moderator, I sincerely welcome all of you to our platform. Today's webinar will be focusing on why there are so many bone graft materials out there. Dr. Jin Kim will be providing a critical review and a much-needed guide for clinicians. I would like to inform you all that you will be receiving a total of 1 CE credit. You must stay active during the whole session, and at the end of the webinar, a pop-up window of a survey will appear on your screen. If you do not see a pop-up, you will also be receiving an email from GoToWebinar with the survey link an hour after the webinar has ended. You will receive your CE certificate by email within 14 business days. As shown on the screen, there will be a question box in the panel board. Please feel free to ask questions in the question box throughout the lecture, as the presenter will address them during the live Q&A session after the lecture. Without further ado, I am honored to introduce our speaker for today. Dr. Jin Kim is a 1986 graduate of the dental school at University of Sydney, Australia. He completed specialty training in periodontics at UCLA School of Dentistry in 1998. Dr. Kim is board certified by the American Board of Periodontology and the American Board of Oral Implantology. He has advanced degrees in pathology, public health, oral biology, and had been in general practice and academia for 9 years prior to starting his career in periodontology. He has spoken at many national and international meetings worldwide and has research that has been published in respected scientific journals. He is the co-director of Global Dental Implant Academy. With that, I ask that you give Dr. Jin Kim a warm welcome to this webinar.
So welcome to yet another session of a webinar through GDIA. I'm very excited because this is a webinar that we are co-hosting with Maxius Dental, one of the leading bone providers in the area. We do have to go here to this. That was a beautiful intro, wasn't it? I made that, so there you go. Today we're going to talk about different types of bone graft material. And again, this is a program sponsored by Dentist USA as well as Maxius, but organized by GDIA and the super team behind GDIA, the organization. This is to introduce Maxius to those who may not be new to this company. It's actually under the umbrellamanship of Community Tissue Services. I personally have been working with community people for almost 2 decades. It is one of the largest tissue banks in the United States, and we're very happy to work with them. Who on earth are these guys? The Bone Guys. The Bone Guys is a local group in Southern California. They work in conjunction with this gentleman, Ryan Bolter, who is the Dentist Midwest representative, as well as a Maxius distributor in that area. And here are some fine people, Colin and Shannon Brown, very special people in my life. Shannon started off as an implant representative from my office many, many years ago. We have a nickname for her. We call her Curly. She came into the door years ago and got befriended, and then we start working together. The husband, Colin, is distributing Maxius. We went to their beautiful wedding years ago, and that was so many years ago. And now they are in charge of this weird group. Let me read out exactly what it says on their website. The Bone Guys is a group of weirdos who love to celebrate the dental lifestyle. What is a dental lifestyle? Okay, we have a passion for art, culture, people, and places in the dental community. Our goal is to build relationships through education, events, and exploration. And sure, they do exactly that. They have been very, very instrumental in helping my practice and many other clinicians all over. So I do appreciate Maxius and the Bone Guys. So, why are there so many bone graft materials? Why? The quick and easy answer is this. It's a lucrative field. Bone graft materials fields is a 2.5 billion industry, according to data from well over 10 years ago. So I don't know what the current data is. I'm sure it's a lot bigger than that. Say no more. That is a big industry. But a little longer reason that I will try to explain in the next 40 minutes or so is the fact that we live in a very diverse society. What does that mean? I'm talking about the society as in the whole globe, not just in the United States or North America. You see, bone needs and demand is different in every culture, every society, different types of availability, but more so the culture, the belief system, say such as religion and whatnot, the regulation, and just a general vast array of philosophies that make certain materials acceptable or not. Now we're talking about dead people's bone. So there's a lot of innuendo in that. In certain societies and countries and cultures, it's just not permissible, whereas others, it's very widely used. So that's one of the reasons as to why it is so diverse. Let's look at Denise. Denise is a young lady. She's actually an attorney. She's a very special attorney. She's an attorney who fights police brutality. So she's very busy right now. She was introduced to me through a referral, and she came in with this problem: missing tooth, significant amount of ridge collapse. She's had several implants done on the contralateral side, which looks fairly good on a 2D image. But now she has problems on the other side, so she's knocking on the door for this particular problem. But when we look at the left side, she says a bone graft was done in a very respectable institution. So then I said, well, let's look at this carefully. So when we look at the cross-section of the three-dimensional view, something doesn't add up. Some form of bone grafting was actually done, but the net result is at least the one in the anterior, the first bicuspid, there seems to be no bone on the facial. The second bicuspid has some structure there, but it just isn't adequate. So, you know, it could have been a technique problem, wrong choice of materials, many things could have gone wrong there. But you know, for one, I do not want to repeat the same mistake, so I'm going to put my heart and soul into making sure this develops correctly. So when a flap is raised, you know, sure, true to the assessment from the three-dimensional radiograph, we have significant amount of bone missing, the bone volume. Luckily, the bone height isn't bad. Soft tissue is thin. These are some of the challenges. So I did a implant placement and simultaneous GBR. I thought about you know, hiking up the tissue. So we actually use, this is actually like the Professor Son's Santa concept, which is a brand new idea of making a very long, tall healing abutment for tenting effect. In fact, Ryan Bolter and I designed this together with Dr. Bazzi, Nader Bazzi, and we custom manufactured these for this purpose. And as the slides show, the grafting was done. Many months later, now I'm uncovering, as you can see now, a regular healing abutment had replaced the previous specialized tenting attachment, and a gingival graft. The free gingival graft is done on top of that, just a sort of very noisy and loud suturing all over. And this is the net result. Now she's ready to go and get the actual restoration placed at the restoring doctor. So this was a case that involved allograft together with membranes, tenting effect, and so forth, and touched upon with soft tissue. And the CT comparison shows indeed an adequate amount of bone. We just have to let this mature and become strong and calcified so that she can function with these for many, many years to come. And the side-by-side comparison of the same area shows before and the after of a significant amount of bone thickness that was regenerated. So technique of choice, right materials, correct protocol, and the correct material. So what type of bone graft material is suitable where? That's the question we're trying to answer in the next hour or so. Some of you may or may not know this, but I was a Christian missionary for many years in my home country. So prior to that, I did attend a seminary, Christian seminary, to get some training in mission work. So I am fairly well versed with New and Old Testament. But this is something of interest. Have mercy on me, Lord, for I am faint. Heal me, Lord, for my bones are in agony. It's a descriptive thing. This is not a scientific statement. This is a very spiritual, storytelling type of thing. When the bones are in agony, it's a figurative speech. But when we look at different versions, a lot of interesting things are observed. My bones are in trouble, according to one version. My bones are agitated, and my bones shake with terror. And then I like this one the most. The Third Millennium Bible says, "Heal me, Lord, for my bones are vexed." Vexed. It's a word we don't hear very often, but this is so descriptive of this gentleman who I saw recently. He comes in because of the COVID pandemic. The offices were closed. He was dying to get in because he's having pain on the lower right. The story is implants were placed. Implants didn't work out. They were removed. Ended up with a secondary infection. So the gentleman walked in with pus flowing out of that lower right. And he literally, to paraphrase, had, "Help me." Instead of, "Oh Lord," he said, "Doctor, help me, doctor, for my bones are vexed." It's almost like straight out of the scripture. So, there is a huge area of bone missing, and you can see how spiritually and physically this gentleman was going through the agony, and how us as clinicians, not as God, as clinicians, need to do something to help our patients. So what materials do we have on hand? This is straight out of a recent textbook by Michael Picos. Everybody knows Dr. Picos, an excellent book that he had written and published through Quintessence just literally a few months ago. And I loved reading the book. They're very well written. So I borrowed this diagram from one of his chapters. And this is the 4 classic bone grafting material category. I'm going to add a 5th one later on for our sake of our understanding, but let's look at these 4 in depth. So there's autogenous bone, your own bone, allogenic, xenogenic, and alloplast. So let's go through them one by one. But before we do that, interesting point. On the right side of this pie chart, you see mineralized allograft account for 37%, more than 1/3. Now, the second category, the 16% to the right, is demineralized bone allograft, which accounts for 16%. Combine the two, well over half. So allograft leads the industry in terms of the volume or amount of material that's used. On the other side, xenograft is a winner of the rest, followed by autologous or autograft, synthetics, and some BMP and others sort of fall into that. So that's the sort of usage. And this is a fairly recent data. This is out of Dr. Rick Myron's new book. Again, this is another book that's out of Quintessence, fairly new, and this data reflects the status of things in 2019. So here we are, 4 different types of grafts, and I'm going to spend the time going through one by one, describing the nature, why they're used, and what are the advantages, disadvantages, that sort of thing. So pictorially, this is always, different types, and you can recognize some of the brands. Some of the names are household, some not. And the little videotape that you're seeing in the middle is a combination, sticky bone. Sticky bone can bring any one of these materials and make it more viable, make it more biologically adapt by adding growth factors into it, and that's how we make this material. So just to confuse everybody, okay, when you look at the literature, I'm not in a position to criticize these particular papers. I'm just listing them because this literature is extremely confusing and there's a lot of conflicting data. if somebody went to the literature and sifts through hundreds and hundreds of data and articles about the thesis as to what is good, what is not good, and so forth, it's very, very difficult to understand the material, number one. There's a lot of clinical bias, there's a lot of commercial bias, there's a lot of things of that nature. So to say literature is clear is an understatement. They show all sorts of data out there, and just like how we interpret Bible, for instance, I could go pull out 20 good articles that support my view and the way I think, and anybody can do that. So, alloplast versus xenograft is just one example. I mean, one article can say alloplast yields lower bone to graft contact than the xenograft, therefore xenograft is better, and you can do vice versa with any kind of material. So it's a very delicate. My take-home message is read those articles with care and try to read between the lines. Who's talking about it? Who sponsored the study, and so forth and so forth. So that is intrinsic to what we are doing here. So let's look at autologous bone or autogenous bone. Same thing, as we tend to shift between the two words. Autogenous bone or autologous is really the same thing, and it means it's the patient's own bone, not your neighbors, not your family. You're the patient. So it comes straight from the patient, goes straight back into the patient. That is the definition of autologous bone, and therefore it requires a harvesting. Sometimes it's local, right next to each other where the surgical site is happening. Many times it's in a different site. So a second site, I'm talking mainly intraorally, but we can go extraorally if we need to. And that's the nature of autogenous bone. The huge advantage, the one advantage that people label the autologous bone as the gold standard is because it contains and it has a potential to release growth factors. Now later on, allografts, we have something similar, but the extent is very, very different. Yes, allografts contain growth factors also, but much more minuscule amount compared to autogenous bone. However, you require the clinician has to meticulously handle, otherwise that good growth factors, which are proteins, can easily get denatured or damaged or expressed in different way depending on how the bone is handled. So one could potentially take very good gold standard bone and turn it into a lousy graft material because of surgical mistakes, a protocol that's not correct, contamination, burning the bone, and all sorts of things which I'll go into in a minute. So these are the common intraoral sites, and this is out of Kalmish's textbook. The symphysis area, the ramus, tuberosity, both to get the blocks as well as to get veneers or even particulate. These are the areas that we can get them out of, and you can refer to the various textbooks. Just clinically, pictorially, these are those kind of areas. The ascending ramus, the buccal shelf on, adjacent to the second, third molar, is a relatively easy to get to. We can get abundance of bone. It's a very traumatic surgery, no doubt, and in the hands of not so finessed clinicians, the patients can suffer significantly. Therefore, there are some complications. In the short time that I've been doing these kinds of work, I've had patients who had the long buccal nerve compromised with lessened feelings. I've had people that had drooping where the mentalis muscle doesn't reattach to the right position if you're not careful with the suturing and the aftermath of the symphysis area. So sometimes you get neurosensory issues of the teeth. The lower incisors in particular can have this notorious wooden feeling. People describe it as it feels like wood. It doesn't feel like my tooth anymore because sometimes we can interfere with some of the delicate pulpal neurological connection there. This is a rather old slide, and you can see a rotary handpiece going in there, rather making a huge, thick trough. Nowadays, we tend to use piezoelectric surgery that tends to minimize that. But as the image shows, you do have to separate the buccal muscle attachments, which is temporalis and other muscles in the area. Therefore, it's quite traumatic. And this gentleman did fine, but from this ramus, he actually had swelling right underneath the eye. So that's how extensive swelling and bruising can be. This is a lady who had failed implants that I'm re-attempting after referral. So in this case, because we had to, build up a significant amount of bone volume, I chose to use a onlay block approach, just like the previous case. But you can see that we have now moved into the era of piezoelectric surgery, so the cut is more finesse. It's definitely less traumatic, and the bone is cut with a little more ease and predictability. So we got a fairly big chunk of tissue. This tissue is called corticocancellous block, as opposed to monocortical block. This is corticocancellous. Is actually why it picked up some cancellous portion. Why is that important? Because cancellous portion contains more marrow type bone, which means there's more BMP and other growth factors, which means there's more vasculature in that area, as opposed to the cortical layer, which is denser, organic material. There's more calcium, more organic matter, less of blood supply, tiny capillary-like Volkmann's canals in the area. So that bone gets nourishment by diffusion. Very different way of getting blood supply. Knowing this is important because it does apply to later when we talk about the allograft and how we harvest and how we use them and so forth. Here we are trying to literally connect this blood supply that comes from the crestal bone, which is now the shortened or the lesser, taller crest. We're trying to build height. Therefore, this cortical layer that does not have its own blood supply, and I'm trying to bring up the blood supply from deeper cancellous layer so that blood supply can nourish and make that bone piece that we're going to place on top to survive. So here, let's introduce you to the progenitor cells. Most of you are familiar with this, but just in case, progenitor cells they're the descendants of stem cells. These are stem cells. We want to try to bring out why are they needed in the action area, because they need to differentiate. Differentiate meaning they change the way they behave in different types of cell, and therefore they're called the undifferentiated mesenchymal cells. I love that word, just rolls off your tongue, undifferentiated mesenchymal cells. And as you see in this family tree, the hematopoietic or the stem cell, the undifferentiated mesenchymal cell, when they get the calling, when they are told by certain signals, the chemicals, the growth factors, they come and trigger them, they say, aha, we're trying to build bone here. Let me get to work and let me start to build bone. And they hopefully turn into some sort of a bone-forming cell. It's a lineage of fibroblasts, and then they turn into ultimately something to the order of osteoblasts and osteocytes. And that's what we're trying to dictate. So we're trying to guide the tissue to go into that direction, hence the word guided bone regeneration. Therefore, bone decortication, which is an essential part of guided bone regeneration, is needed in this type of situation. Now, I'm going to dwell on this point a little bit while we talk about the autologous bone, because same thing does apply independent of what bone graft materials you choose to use. So these are the common, frequently asked questions at seminars and training programs that we conduct. Is decortication really something that's needed, and what does the literature say? Well, to tell the truth, to prove a point, if somebody has to do a master's or PhD and says, my job is to say decortication is unnecessary, for instance, and now I have to go and prove that using that null hypothesis. If I were a supervisor, I would say, tell me how you can do that. It's almost impossible unless you have so many cases side, and the best clinical research we can do is split trials. One side you decorticate, exact same protocol. The other side you do everything the same except no decortication. The reality is such things are not feasible in real life. So the vast majority of the studies you see here is Gary Greenstein's comprehensive review of this topic. There are no human studies. These are all dogs, sheep, rabbits, rats, you name it. So they're trying to emulate the human, but it is not real. Now, this is one of the more interesting papers that I sort of dug through. It wasn't actually in there. It's a rabbit study still, but um, reading through this and understanding this, let's read the bottom line here together. We conclude that larger perforation is associated with prompter bone formation in the circulating space during GBR. And I have reasons to say, this research was quite valid, so let's take home that message. Point is, when you perforate, you want to perforate big. There is a limit. You don't want to create a humongous hole so it's just gushing out blood, but the perforation has to be big enough. So those of you who are looking at that left image and say, boy, those are big holes. Yes, we are talking about, let's say, number 4, carbide round burrs. Yes. And how deep? Go deep enough until you hit the cancellous chamber, the marrow space, and you see, relatively good flow of blood. Regional acceleratory phenomena happens when this kind of subclinical injury happens. You're literally hurting the bone to make it grow more bone. So this is a case that was relatively well finished, and we were able to get the height and the width we wanted, and the implants were placed, and happy ending was there. The guided bone regeneration concept was born out of 1994. In fact, that was the year that I got married, and today happens to be my wedding anniversary. My wife is waiting here anxiously because we're supposed to go to dinner, so I need to finish in a hurry. 1994, 26 years ago, this gentleman talked about guided bone regeneration for the first time. You need to have adequate blood supply. You need to have selective cell repopulation. Cells have to go there, bone-forming cells. The cells that love to form bone, and nothing else has to be the main characters. In fact, they have to be the only characters. And they also have to have this good supply of progenitor cells, stem cells, undifferentiated mesenchymal cells we talked about, and there has to be a lack of micromovement. We know this so well today, but at the time when these were laid out, people said, oh, wow, well, that makes sense. And then that's when the membrane therapy was brought into place. A few years later, actually more than a decade later, Hong-Lei Wang and his group sort of reiterated this with slightly different emphasis, same principle, but he made it easier to understand by calling it the PASS principle. Primary wound closure, angiogenesis, space creation, stability of the wound. More or less the same thing, packaged in a slightly different way. Now, there's a few things I may or may not agree, but this is what the guided bone regeneration is. And again, we're talking about different types of bone graft material, but independent of what graft material, these principles still hold true. So autologous bone, as you saw in the previous case, is not an easy thing to do. It's very invasive. It's technically difficult. The patients end up with bruising and swelling. Yes, that happens more times than not. So we have to then look at, is this all worthwhile? I want to really look at this article and let's dissect this a little bit more. This is again Rick Myron, a great researcher, and his group did this paper in 2011. They looked at 4 different ways of harvesting autologous bone. So here we are pictorially at the Quinton mill, which is the most popular. You take a block of bone and you grind it up and then you make it into particles. What's the purpose of that? Well, the particulated bone is more fitting in certain situations. You can pack better, you can mold it better to a certain shape. But remember, we are trying to release the growth factors that is embedded inside the bone. So particulating has different innuendos if you really think about it. So that's one way to do it. Now, the second instrument that you see on the top is a Hugh Freedy instrument, a bone scraper. It's basically a back action chisel with sharp edge. So you scrape the bone. You could be scraping cortical bone initially. It might be going into cancellous space, but when you scrape, you are again getting smaller pieces, chips, scrapings. You are expressing more growth factors, which might be within the BMPs and whatnot, are being harvested, are being expressed as they come to the surface. The third instrument is a bone trap. The fourth instrument is a piezoelectric surgery device, as many of us know. Now, the bone trap, I find this one to be a little bit uncomfortable. I've used it in the past and I stopped using it. And this is just one example. There are different variations of it. In general, they use a suction device, a vacuum, to pull the particles into this trap. And by the virtue of the filter, you let the liquids go through, but the particles get trapped. Very neat concept, and why not? However, let's look at this. The particles that you pick up better be 100% bone, because as you use, say, rotary instrument or some other instrument to pulverize the bone, you could be introducing non-bone, saliva, soft tissue, calculus. Gosh, I mean, there's a lot of things that can potentially go in there, so it's got to be meticulous. And let's assume that it was the case. 100% bone, nothing else, very, very well executed. But then these bone, how do you assure that the bone pieces are uniform? You might have little pieces. Some of the bone cells might be torn, severed, crushed, destroyed. And then the third factor, high volume. You know, when high volume suction sucks this through, even the healthiest of the cells might go through damage simply because of the sheer air and the vacuum going through. So, needless to say, a lot of this bone ends up dying. And, therefore, we need to rely on good scientific study to look at this. And this group has proven, they have shown that of the four techniques, the suction method was not good. Even the piezoelectric surgery method tended to destroy the bone. So the only two recommended based on this was the Quinton mill and the scraper. So take it for what it's worth. Those are the two methods that's preferred over the other two. So this is yet another sort of a variation of the same theme. It is a bone scraper that has a blade built in and a chamber that you collect. So this one works fairly well, but you better make sure that what you're scraping into it is all bone, nothing else, no saliva. What does saliva contain? A lot of enzymes, amylases, collagenases, and whatnot. Therefore, as soon as the enzymes enter this chamber together with bone and the BMPs and the proteins and the growth factors, which are all protein, they will melt them and they'll denature them, they'll destroy the protein. So be very careful. Now, that wasn't listed in the last study, but this is a very common way people take bone through the drill. You drill, oh, there's some bone stuck there. Let's not throw that away. Let's collect it. So like I've done here, put them in that little chamber and say, great, gold standard. I was told this is gold standard. Therefore, I've got the best bone for free. But take a look at that bone. Look at the color. It's ivorine. Now, it could be simply because it came from a very dense area, such as, posterior mandible and so on. But it could also be because as the drilling happens in a certain RPM in a heated environment, it could be that the particles are just so tightly jammed, it might look ivorine without any vasculature. There's hardly any blood seen on that one. So on this topic, I know Columnish published on this, but I couldn't find the right reference. So I'm just going to say personal communication because I did indeed speak to him about this on many occasions, my personal mentor, my respected teacher. He states that red, ivory, and brown, the brown, the black, or the cooked, forget that. That's got lots of necrotic factors, so you should just toss them out. But he actually cultured these different types, and the ivory color did not have a whole lot of vital bone. Only when it was just juicy red that you could use that. So when you do this, be very careful. Number one, make sure that there's nothing else besides bone. Number two, look at the color. Did you traumatize it in the process of osteotomy? If so, toss that out because you do not want to throw in unnecessary material. One of my dearest patients, actually my youngest son, he was a year and a little over a year. You can see he has a little lesion, congenital cleft palate and lip, which took a team, an orthodontist, a maxillofacial surgeon, plastic surgeon, myself, all of us got involved with this case. And eventually we got a beautiful tooth through there. In his case, he had received an extra oral autologous graft from his hip. So allograft is the next topic. Allograft is, of course, the most commonly used material in the United States, counting for more than 50%, as I mentioned. And when we talk about allograft, let's talk about the development of allograft. And we just cannot talk about this unless we bring in the war history. During World War I, World War II, a lot of the military personnel returned crippled, seriously injured, and whatnot. But it really wasn't until the 50s and 60s, the Korean conflict and the Vietnam conflict, then wounds of smaller sizes came back. And it was up to the U.S. military and the medical, establishment to try to deal with those kinds of injuries. And that's when the intensity of trying to graft bone into smaller sites became intense. The gentleman that you see there with the glasses, the way I wear glasses, so we have something in common. His name is Marshall Urist. He was a prominent researcher. He actually had a very illustrious career, and I think at UCLA bulk of the time. And he was the one that identified, or part of that group that talked about the BMPs and how we can make allografts, because allograft treated in a certain way, we're going to express BMPs, bone morphogenetic genetic proteins. In essence, the allografts are bone from the same species, human beings, same species as the patient. It has osteoinductive growth factors present. It could be small, but nonetheless, it's there. So all the bone banks and different protocols are all focused on how can we do it so that there's maximum amount of growth factors presented, expressed without destroying the growth factors. How do we make it better? And that's what the allograft industry has been doing over the past several decades. Remember, we started this journey back in the 60s after the Korean conflict. So it's the most new bone formation is through the matrix as well as the protein. Let's tune back to one of my early years, a case that I did almost 20 years ago, 2001 to be specific. This gentleman presented already with one implant in the first molar. As you can see, it was a previous bridge that was being converted to an implant, but unfortunately the second molar was unrestorable. So I had to change the treatment plan and extract that molar. It was an endodontic failure with a furcation defect, so old slides. So we extracted the tooth, and then of course the socket management was done. The socket was filled with a allograft material, mineralized allograft. I will go into the details. And instead of putting a conventional membrane and closing the wound, as most people are led to believe to do, I left the wound open. It's an open wound technique. What is the advantage of that? Open wound technique is to allow more keratinization with rich width and height. And there are many methods of doing it. This was actually using a particular product called Capset, calcium sulfate, plaster of Paris, medical grade plaster of Paris. Remember, this is a period of time, 2001. We did not have PRP, PRF. We did, but it was very preliminary stage, so I was not using it routinely. We basically hydrated the bone in sterile water or saline, and basically what you see here is a loose suture, not to try to pull the flaps close to each other, but just try to get a meaningful closure. And in 7 days, look how beautifully the tissue reacted. The second and the third slide is exact same day. The only difference is I just removed the sutures, chromic gut suture, which is a removable suture. And what you see on the right side is that indeed, in that 7-day period, soft tissue had grown, namely keratinized tissue has grown, and the ridge width and height seems to be remaining fairly stable. So that's exactly what we're looking for. In the center, we have some clot. It's actually fibrin clot, which is very welcoming. So several months later, we go in, and instead of doing a straightforward osteotomy, I decided to take a core of the bone out. The patient agreed to it, and we took the core out. We said, let's contribute to science, and this gentleman is an engineer, and he said, why not? Let's do this. So this piece of bone was taken out, the implant was placed, and you can see that the keratinized tissue is abundant and pretty. And that piece of the bone was sent over, and this is actually at 8 weeks, to Seoul National University. I have a lot of colleagues. We do a lot of collaborative work, and this is the histology of this case done in Seoul National University. And the assessment of this is the histomorphometrics say we have roughly about 1/5, 20% of new bone which is significant at 8 weeks. And to understand this image here, in the center you see a empty lumen where you actually see osteoblasts, and then you see in the immediate periphery we see osteoblasts, osteocytes. Now when they're trapped inside bone or calcified structure, that's osteocyte. And then you see, I don't have my pointer, so you see yet another lacunae where there is no cell. That is bone. So this is actually the center of this is actually the center of a new lacunae that's being formed by new bone formation within the piece of allograft. This is very promising. So that's how you interpret the histology. Now, I twisted this gentleman's arm one more time at 14 months. This is after the implant was placed and just about to be restored. I said, can I please go back in there? I am so curious as to how the bone is doing. Let me take another core. And this gentleman was a sport, and he allowed me to do that. And of course, what you see was much more bone that had developed, and eventually the case was restored. So I was able to see roughly 20% of bone in that 8-week period. Seen, it went up to 25-30% roughly of new bone at 14 months. So that was very, very promising. Now you see this is now a 19-year follow-up. This gentleman was seen right before the COVID outbreak, and then I was able to see him for a CT, and that shows a 19-year follow-up with good bone. So almost 20 years ago, with rather cruder and simpler technology that we had, the bone remains more or less the same. Of course, as the years go by, the bone industry develops itself too, but more or less similar type of bone material was used back then. And we can say this allograft has the osteoinductive property as well as osteoconductive property. Now, to put that in plain English, osteoinduction means the bone itself causes new bone formation. So what makes that happen? It is the proteins within the bone particle. Again, relatively small amount, but nonetheless it's there. So then it goes to be how important it is for the bone bank to do the meticulous protocol to deliver this all in this little jar so that the proteins are ready to go when you open the jar and get your surgery going. Now, if there is no protein, for instance, or virtually none, then it's simply going to act as a matrix where bone grows in between from the surrounding, and that's a concept of osteoconduction. The xenografts and the alloplasts cannot be osteoinductive, therefore by definition they're osteoconductive. Autologous bone obviously is clearly osteoinductive. So that's the difference. Now let's look at how bone forms. Back to the basics. We're not going to dwell on this very much. This is from classic Lindy's textbook, and in there's a chapter by Klaus Lang on this concept. And in I can't even pronounce it. I think I spelled it wrong. Endochronal bone growth is when you develop as an infant in the developmental phase. So that doesn't apply to us. What we are looking at is intramembranous ossification. I pronounce this one a little bit better. Intramembranous ossification. Now, if you look at the cycle, let me go into that. That is when, like we talked about, the stem cells, the cells we want to bring to the action site, they turn and say, hey, what's going on? Oh, there's a party going on. You want me to participate? Yeah, I'll join. And then the mesenchymal cell, which was nothing to do with the bone, all of a sudden says, this is a bone forming party. Let's get down. And then it forms bone, becomes an osteoblast, and so forth. And that is scientifically drawn in these diagrams. Now, similar thing happens in the normal remodeling phase. Therefore, once the bone forms, similar thing happens. A bone melts, bone is redeposited, therefore new bone is constantly remodeled with time. And this is a series of slides that I've collected over the years. The earliest bone formation, some people like to call it a spindle bone because it kind of resembles a spindle, like sharp needle shape, where the new bone is formed. And if you look at that image carefully, I love this image. Look at the row of osteoblasts all lined up like ducks. and then they're all sitting there, all like secreting out calcium, and that calcium sort of forms a mass, and then it just becomes a block of very, very immature new bone, as expressed in the dark spindle shape there. When more and more of that coagulates, it becomes woven bone. Woven bone is the earliest form of bone. It resembles bone, but it's the weakest. It's not organized yet. And when true remodeling happens, then we call that the trabecular bone. And at this point, we see all the features. We see this concentric lamella formation, this rings of cut wood surface appearance. We see the cells lacunae embedded. We see the Volkmann's canals. We see, these nutrient canals where blood vessels and nutrient fluids pass through. So similar activity happens in sockets, and we all know how sockets heal. It's basically you need to put some sort of matrix in there. Sometimes it's clot, and sometimes miraculously just with clot bone forms. But many times the clot itself is not able to hold. The buccal and the lingual plate tends to dissolve away. So by putting some sort of matrix and keeping that intact, we have a successful socket grafting. So allograft does osseoinduction, as you saw in these previous images. So, bone of this nature, allograft bones aren't expected to do that. But here's some of the challenges, practical challenges. You go to your friendly bone rep, or you go to a booth in a show and say, I need to buy bone, help me out. Where do I start? And then your friendly rep will show you this beautiful brochure, colorful brochure, and then you stare at the menu and say, I don't really know what do you suggest, because there's so many choices. So let's see if I can help you. The first choice you want to make is, do I go for the mineralized or the demineralized? And I don't want to oversimplify it, but this is what you need to know. Mineralized allograft, as we call it, is used for socket grafts, ridge augmentations, sinuses, and most of the implant-related things. When do we use demineralized? I would say more for periodontal defects, periodontal regenerations, and so forth. That's how I draw the line based on the literature. Why? Demineralized bone tends to form less dense bone. It tends to form more marrow-like bone. Therefore, in the implant world, is not as useful. Whereas in the periodontal world, because it means differentiation is less advanced, some of those bone-like cells can potentially grow into becoming the periodontal ligament. Therefore, the more we demineralize, the better chance, because we're starting further back in this lineage. Now, there's something that I'm going to tell you that's going to confuse a lot of people. What the literature, the brochures and so forth, is the nomenclature that we all use as mineralized allograft and demineralized allograft is all demineralized. Okay, this is confusing. Truly, the way it should be worded is mineralized is a little bit demineralized, and demineralized should be a lot more demineralized. So what does it mean by demineralized? When somebody donates bone, let's say I want to be a blood body part donor, I want to volunteer, go to the DMV and register myself, so if I ever die in an accident and whatnot, and people say, he's a young guy, I can fold him. No, I think the cutoff line is somewhere in the 50s to 60. I think all bone banks and tissue collection agencies do different things. Now I'm told that the community tissue has a more stricter guidelines. They are the largest tissue bank in the United States, so I guess they have that sort of authority, and they have that leverage, so they can say, no, we don't accept people, you're too old, go away. They'll say that to me because I'm way over 50 now. So younger people without diseases, without any bone-related disease, without carcinoma and so forth and so on, so there's strict guidelines as to who they take. That person's bone is then taken to the tissue bank, and they typically take the long bones and place it in acid, something like 16 moles, some pretty strong acid overnight. So the time and the length of that demons to leach out and wash out the calcium, how much of that you do determines whether it's demineralized bone or mineralized bone. But again, they're both demineralized. Okay, why is that important? without demineralizing, going back to that spindle bone, without exposing the collagen within the bone particle, you cannot allow osteoblasts to sit down and lay down the calcium. That's the reason why. So, for instance, that's how you get osteoinduction. If you have chunk of hydroxyapatite, which is calcium, then cells have a very difficult time laying down your bone on top of that. So demineralization is done for that purpose. So you look at this menu and say, okay, I get it. So demineralize and mineralize. And then they say, do you want cortical? Do you want cancellous? I don't know where to start. Now, I did mention earlier on, cortical bone, if you remember the autologous block, the cortical bone is that surface area that's very dense, very well organized, and highly organic calcium layer, not much cancellous or cortical, not much trabecular bone, whereas cancellous is that mushy stellate reticulum within the marrow space. So there's more proteins in cancellous layer. There's more calcium in the cortical layer. So then I say, so tell me more. So the cortical layer, oh, this is not the right, that's the right slide, yeah. So the cortical is on the outside, it's harder, cancellous is on the inside, so therefore cancellous particles contain potentially more growth factors. Good point. And then you go down the menu and says, do you want large particle sizes? Do you want small particle sizes? And you get even more confused. Okay, small particle sizes versus large particle sizes. What does the research say? What does a clinical experience combined tell us? Earlier on, we had, people all over the board. At this point of time, I think this one has been cleaned up pretty well. Small particle sizes, and I will define that as, let's say, roughly smaller than 0.5 millimeter, 500 microns. Okay? So if you have, say, 250 micron particles, and you get that because it was on sale, the chances are the small particles are going to coalesce. It's not going to give you the volume. It's going to coalesce, and some people get concerned when the particles are so close together, how much blood supply, how much space do you allow for smaller cells to penetrate in and do their job? Because we need to get the progenitor cells in between, and that passage has to be there. So some people say, don't pack the bone too hard, just loosely pack. We've heard things like that. The large particles, on the other hand, there are big pieces and more spaces in between. Therefore, you can allow more cells to go in and so forth and so on. The bottom line is, I don't think anybody's too sure if you stay within, let's say, 500 to 800 microns, clearly under 1 millimeter per particle, we're in the right range. And do remember, not all particles are very, very uniform. There's some variability even in one vial. So that's what you need to remember. I'm not Irish, but this is a proverb that I like. What is in the marrow is hard to take out of the bone. Again, I'm being a little philosophical there, no scientific statement, but an interesting point to make. This is Harold Frost. I like this gentleman because his research and his thoughts have heavily influenced the orthopedic industry and our understanding of biology, especially in the dental implant field. Harold Frost is the one that brought the term regional acceleratory phenomena, RAP. And in that, we are talking about how do you get the bone environment to get challenged and they want to get going is pretty much what that's all about. So when you have smaller sizes and larger sizes, one thing you have to consider is think about it. Small sizes actually allow more bone to be, growth factors to be expressed, assuming there are some growth factors in there. Large particles tend to not do that, but we may need the large particles because it holds the volume together. One of the key elements of guided bone regeneration is space making or minimum movement, micro movement, and large particles contribute to that. So the bottom line is we need a combination of both. Now the next item here is large vial size, not the particle size, how big the vials are, the content, small. So, when you go to Costco, you buy tons of things in bulk. So can you do the same thing here, buy the big ones and divvy out? Now, I must admit, we do that in the Mexico program. We tend to use the large vials, let's say the 2cc, because we typically have 4 surgeries going on all at once. So we open one vial and we divvy out. So it was called the concept of multi-dosing. And that works because so long as we contaminate things, it works for economies of scale, of course, and that's just exceptional circumstances. But in an individual private practice, especially in this COVID era where cross-contamination is going to be a key thing, all of us are going to be extremely careful about. I think multi-dosing may not be the right thing to do. I do want to address that because it is something, questions we get all the time. So choosing the right size, and let me give you a little guide here. 0.25, I rarely use those because they're so small that you're going to get frustrated. You're going to have to open another jar. So 0.5 is usually my go-to for a small socket. When I say small socket, anterior, perhaps a bicuspid. But if it's a bicuspid of large size, some more defect, and a molar, I'm going for 1 cc. And then 2 cc is typically for a large ridge or sinus augmentation, that sort of a thing. So that gives you some idea. Just another small pointer. The industry standard is 2 cc. Milliliter is the same thing, cubic centimeter. But grams is kind of a synonymous thing. If somebody says, give me 1 gram of bone, we're talking about 1 cc of bone. It's a unit that people tend to interchange. It's roughly similar. So that's another thing you can use. Here's an interesting study that the Maxius group has presented. This group of researchers basically took the bone, opened them up, because once you open, what happens, this is freeze-dried. Allograft is freeze-dried bone graft material, which means moisture is taken out, so it becomes very crispy, dry particles, just like we do freeze-dried coffee, and then you open instant, coffee as powder, but it's very dry without moisture. So once you open the vial, what happens is immediately the moisture from the atmosphere, the air, will start to saturate. I am told that the industry standard is to keep the moisture content less than 6%, but once you open, immediately it goes up significantly. So the bottom line is, do not do multi-dosing and choose the right size vial for the right indication. So having said all that, now we talk about the sizes, different cortical cancellas, different particle sizes, the vial sizes. How do we choose this? This is probably a very safe one to go to for general use. As you can see, what's in the middle of the screen is exactly what's in the bottle to the right. You can see it's a 1 cc DM1010, whatever that the item number is. But the point here is cortical mineralized bone together with demineralized blend. And I believe it's about 50-50 blend. I may be wrong on that, but I think it's roughly half and half. So what's the advantage of that? Cortical mineralized is denser. It holds the volume. It resists resorption, because what do you want? What do you not want? We don't want the bone to start collapsing real soon. Otherwise, the socket, the sinus will not do the job. So we would need that. But because that cortical mineralized component does not have a whole lot of growth factors, you want the demineralized cancellous portion. So by combining the two, it seems to be the best of both worlds, and many bone banks are now starting to do this formula, and for Maxius, this is the one. There are some specialty items. Here is a DBM fibers, and I guess the indication for this, honestly, I haven't used it, but let me tell you intuitively where I would use this. If you have a very tight defect, where you really want to get the bone in and you want the bone to stay there, this will be kind of a good material. But I want everybody to understand, when it's demineralized, you do not get dense bone in the final outcome. You tend to get softer bone. So you have to be careful about that concept. Okay, so use this for its properties, maybe in a sinus where it's very hard to manipulate things. Sharp particles might even puncture through the membrane. Maybe you may want to use these flexible materials. The putty, my concern is it is a great material, but do understand they do come from the spine orthopedic industry. That's where they originated from. They do have biocompatible material gel that holds the material, and it's for convenience, really. But you're paying a little more price for convenience. Sure, you squirt it in and you're done with the socket or sinus. But in today's world, where you have other alternatives such as sticky bone, I would say I have better choices than that one. So there's a variety of different forms of this material that we will go into. So one of the things you saw there is the block graft. I find that to be fascinating, and I've been using that for quite some time. Take a look at this young lady. She has a skeletal class 1, but physical class 3 because of the collapse of the premaxilla. She is a mother of an endodontist, and she was referred to me because she has this problem. Facially, she was just not happy with the way she appeared. And when you look at her, why am I not advancing? There we go. This is her intraoral images. This is a case from 2005. My golly, 15 years ago. And she was wearing full denture in the lower. In the upper, she had lost a premaxilla volume, and she looked class 3-ish, and she was at the mercy of the flange, an acrylic flange that kept the lip support to look reasonable. So she wanted to go with the fixed implants, but how do you give her implants and give her the bone volume and the lip support all at the same time? She has autologous bone, but she dreaded cutting into the jawbone. So we said, let's give allograft a chance. So you can see the anterior ridge is knife edge literally, and I used this is after the full flap was raised, and I actually used a block of allograft to form this, and eventually successful implants were done. So this was a secret. Again, same principles. We clean the area devoid of all soft tissue from the surface of the bone, create large decodification for regional acceleratory phenomena, but also to gush out the blood. We want that fresh blood, the supply of progenitor cells, undifferentiated mesenchymal cells going there, and then reshape the allograft accordingly. And if you ask me if this is mineralized or demineralized, it's mineralized. If it's demineralized, it'll be flexible, putty-like. Okay, so to have its volume, it has to be. And you can see how firm it is because I'm securing with some screws, some GBR screws. And as a result, not only did we get adequate bone for the implant placement, but her profile changed. And she had this advancement in the premaxilla. She really, really loved that. So it can be seen from all directions as to how nice the physical outcome was, and she was a very happy camper. So that takes us to the next category, and that is a xenograft. Xenograft is typically from different species to us. And most commonly is bovine and equine. Bovine is predominantly the most common. Equine comes from Korea. I don't know of anybody else, anywhere else, but I'm sure there are some other supplies, but that's pretty much what it is. Xenographic bone, by definition, is something that provides osteoconduction. There's no need to look for BMPs and whatnot. So basically, we're using the organic component of this animal source bone, and the process is sintering. It's basically introducing this material into high heat. And by the way, these are organic animals, cows, horses. Once upon a time, BioOz is the biggest company, and they, BioOz used to make bone from Swiss cows. After the the mad cow disease scare in Europe a decade or two ago, now the source is Australia. So go Australia, Aussies down under, they create the organic cows that's exported to all over the world, and they process bovine xenograft in more or less the same way. And the bottom image that you're seeing is the three-dimensional image of how the structures look. And that's very similar to how real bone, hydroxyapatite in human bone, looks like. Now, BioOz, obviously, by name, is the most popular material. It's been used for more than 2 decades successfully in Europe. Why is it so popular in Europe? Let's answer that one. In Europe, most countries do not allow allografts by regulations and by many reasons. So by default, they have to resort to non-human bone, and that's why biomass has had its footing in European arena for many years. Many Asian countries, because of number one, sheer lack of allograft sources and government regulations, cultural limitations, so on. People don't like to use other people's bone, so other materials become relatively easy to use. Now, at one point, this is a 2006 article. This is actually our group. I was a co-author on this paper. At this time in the early 2000s, Korean market was consuming significant amount of biomass. So we wanted to know, number one, is this a decent material for sinus graft? And then it sort of evolved into, can this group develop other bone? So this was an interesting study. This was a two-step. We placed the biomass into the sinus, and then 6 months as we were placing implants, we took biopsies right next to each other so we can have serial comparison of a 6 months. What you see on the left side is a 6 months, and the pink represents new bone. The sort of a whitish crystalline structure represents the remaining biomass particles, and the same on the right side. And the voids are spaces and soft tissue in between. As you can see, there's more pink on the right. In other words, in the first 6 months, only so much new bone formed. Another 6 months in the 12 months timeline, more bone formed. What is interesting in this paper, though, if you look at the numbers, and these are some blowouts, when you look at the numbers, when you look at the mean of this series, the amount of bone at 6 months combined average was about 18%. That jumped to 26% at 12 months. So that's a good thing. But if you look at how much bone still remained, at 6 months is 29% of biomass particles still there, and that amount in 12 months, and it was just only 1% less. The little bar graph BHA, that's what that is, just 1% less. So this material unfortunately hangs around for a very long time, which is, at first instance, not a good thing. Relative to the new bone, there's too much of this old material that just doesn't disappear. That's not a good thing. However, if you think about it, hey, how can we use it to our advantage? So let's get to that point. Just another side note. So after that study was published, Korea was interested in developing similar bone. As you understand, in the past decade or two, a lot of Korean biomedical industry has produced implants and regenerative materials and so on. So this is another paper from a group that I was affiliated. They actually made Korean version of biomass, and then they tested it and they verified that it's good materials. So that's what that is all about. Now, a xenograft of exact same nature is made by Maxius also, and basically is Maxius xenograft. That's what it is. As you can see, the macro structures, as you can see in the scanning electron microscope, is very similar to all the other material out there. There is a pore, as you can see in one of the images, that allow osteoconduction, that allows new cells to grow in. So, in the United States, where allograft is much more popular, I would, allograft is my go-to, but I'll tell you where the xenograft comes into place. And this is a good example. This lady comes to see me in 2004. She needed multiple implants. I gave her a comprehensive treatment plan. She couldn't afford it. In fact, she had a shock. She disappeared. 4 years later, she comes back and says, I need your help because something didn't get done right. So 4 years later, after all these implants were placed elsewhere, we had to bury her sobbing story. I'm sorry, these implants are not in the right place. You don't have any bone around it. Let's start over. So unfortunately, she had to lose all these implants. I think the implants were poorly placed. I think they were placed too facially, resulting in all the buccal plate just disappearing and having this dehiscence and fenestration everywhere. So these implants were carefully removed. Now I have to build up a significant amount of bone. So titanium screws were used as tenting. We need some physical space maintenance. And the first layer of the bone here is mineralized allograft. You guessed it, mineralized allograft. I use purely mineralized allograft, not a cortical cancellous combination, not a mineralized, demineralized, just mineralized. This is what I did at that particular time. So this is particulated bone, but as you can see in this menu of lineup of the products, you can see fascia form, the laminar bone, cortical pins, blocks. We talked about blocks already. The cortical pins would be another alternative. Instead of having these titanium screws, you could drill holes and put the dowel pins in there. We'll do the same thing. The nice thing is these screws have to be removed. The dowel pins made out of cortical pins do not have to be. So there's a little bit of a trade-off there. So I think that might be a useful thing. And then here is a good use of xenograft, a very good example. Xenograft is used as an outer layer, a more superficial layer. And again, this is a sticky bone. I'll talk about that in just a minute. And layers of pressed CGF, concentrated growth factor. Some people like to call it platelet-rich fibrin. They're the same thing. We can interchange. That's not a big deal. Concentrated growth factor, platelet-rich fibrin, they do pretty much the same thing. It intensifies the growth factors. The allograft, remember, has growth factors. I've added more growth factors using the sticky bone protocol, but xenograft doesn't have any growth factors. So, extra layers of this will replenish the lack of growth factors in that area. Careful manipulation, suturing. We gave her resin denture with a metal framework so she doesn't have any flexure and hitting. And then 6 months, let's identify how.
So stop recording? No, they're recording now. Yeah, it is recording now. So it's screw heads that will tell us exactly how much.
So you can see that when I raise the flap, a significant amount of bone growth has occurred. And as a result, actually, turn the volume down, I'm sorry. And as a result, we're able to drill, and that, as you can see, is fairly solid. Don't take that bone and reuse it. That's on what's on the drill. Toss them out. Not very good bone. Okay, so you can see the bone is adequate and thick. And the use of this double layer of xenograft on the outside, allograft on the inside, that turns over faster. Xenograft that does not turn over very fast. Our study showed 12 months later, 6 months later, only very small portion resorbs away. So the name plants are now placed. Now, even after that, we added more layer to get that more advancement of the anterior lip support, more security that the threads will never be exposed. And that's a concept called the contour augmentation that Danny Boozer and the group from Bern University has proven to be a very, very predictable protocol. They have done this with almost 20 years follow-up, and they show some magnificent documentation of how the buccal bone can be preserved this way. Their protocol and the way we do is slightly different, but the concept is there. We put xenograft, non-resorbing material that tends to slowly resorb, slowly remodel. We put that in the area that's needed the most, which is the buccal plate area. So that's the concept of contour grafting, more soft tissue manipulation, grafting and whatnot, and eventually uneventful, nice clinical result is achieved in this case. So that's how you can use xenograft. Now, I don't have a slide here, but conceptually, let's say you have a socket, and at the last webinar, I did talk about the socket grafting techniques, and those of you who missed that, please go and see that. But let's say you have a socket. A very predictable way to do socket, especially even when the buccal plate's missing, is to put sticky bone with allograft in the center, and on the buccal surface where you anticipate a lot of collapse, add some xenograft on that area. You can use lamellar bone, like our colleague Daniel Thousand, our periodontist friend, that showed last week, a week ago, on a different webinar. Again, if you missed that, go watch that. He used lamellar bone to do exactly that. But these are very innovative use of different materials for the purpose you're looking for. So that brought us to the last topic of the alloplast. Alloplasts are synthetics. I don't want to sound derogative, but alloplasts are desperate materials. Not in that sense, but here's the thing. Desperate meaning I don't have any other bone. And I'm not talking about the United States. I'm talking about elsewhere. So yes, all of these materials are available in this country, but I say why? Why choose these materials when you have other superior materials? So alloplast to me is not on the top of the list. Calcium phosphate, beta TCP, hydroxyapatite, corals, polymers, bioactive glasses, and ground tools, which I'm going to talk about a little bit right at the end, is some examples of alloplast. So just to show you a point, Cecilia is yet another attorney. She is a good attorney. And unfortunately, she had some work done that did not turn out too good. These implants are failing, lack of buccal bone. So we're scratching our heads as to what went wrong. I think there are several factors involved, but I couldn't help. The bone volume is so thin, although the same story, she said, I had a massive graft done. I don't know what happened. Where did all that bone go? So when I raised the flap, because we were going to remove these implants and start over, take a look at the slide on the right. This is a blow up. Look at these beads sticking out. Interesting, aren't they? They're like little balls, crystal balls. In fact, this is a product called HTR. I don't necessarily mean this is a bad product. That's not what I'm implying. It's just when products are not used properly, the polymers, yes, scientifically speaking, these are polymers of PMMA, like acrylic resin, like we use in dentures and provisional restorations. They do, in the right circumstances, will turn into bone. But let me be frank, I went through the 90s when these products were massively marketed, the HTR brand. Again, I don't mean to be derogative to a particular product, but I'm just telling my experience. I think there was lack of understanding, and many clinicians jumped on and said, oh, this is such an easy material, shove it in, just close up, and it's all done. I think when we have this cavalier, not very well thought out concepts, what happens is these materials get trapped in soft tissue and they never turn into bone. I think that's what's going on here. So it may not be the material, but it may be the protocol. But nonetheless, here's an issue. Years later, you still see these beads, so clearly it's not working out. In this case, I popped those beads out. You can see some of the depressions. Those are not decodifications. That's basically, little crevices formed as these crystals, the circular shapes are popped out, regrafted using the layering technique. Again, that the titanium screw, we could have used a dowel pin, like a cortical pin, mineralized allograft. We could have used lamellar bone. There are many options we have today with a good library of good product lines. But the concept here is allograft on the inside, be it cortical cancer, I really don't care. Allograft on the inside, xenograft on the outside. If you have sticky bone, if you want to go that route, it's even better. And then use a membrane appropriately, primary closure, and eventually we reconstructed the whole mouse and we gave another happy ending to this lady. I did for a little while use Cerasorb in my practice, and the Cerasorb, at least in my hands, worked fairly well. But one of the key things, this is technique sensitive because you have to wet this in pure blood. So it almost requires you to do some blood draw. Now, today that's not an issue because we do sticky bone or PRF or concentrated growth factor almost routinely in today's world. So this wouldn't matter. But back in those days, finding blood was not the routine. But once it's actually saturated with blood, what happens is new bone grows inside and slowly it turns into new bone. It is time consuming. So I actually have some nice cases with the Cerasorb material. It has worked well. But honestly, when you go down the list of priorities, my go-to is an allograft. Autologous graft as needed, but allograft does better, more predictable, easier protocol, and xenograft is niche area. Then alloplast, I really have to struggle to see where I can use that in my practice. If somebody gives it to me, I'll consider it, but it's not something I will be actively seeking out. So the fifth category that's not really in this box is the autologous tooth, MTB. Now, I gave it that name to this company in Korea. It's called MTV, and their promotion was supposed to be this MTV music by, Sting. Anyhow, this is a case that Dr. Jill Park, one of our colleagues in Connecticut, has shared with me. This is a case where she did a split mouth design. She puts beautiful implants in here, and on the one side, what you see on the left of the screen, a little bit more transparent and crystalline, is the ground tooth patient's own tooth that was prepared, demineralized, and put in there with sticky bone form. What's on the right is a combination of allograft and xenograft, like you had seen in some of the previous cases. And she did the comparison, and basically she's done this split mouse design. She's done quite a few, and we're trying to publish some of these cases together, and she's had nothing but great results. So I think there's something to be said. Now let me share this slide. This is a product on the market also. We extract teas, put it in a, lack of a better word, a coffee grinder. It's actually a one-time use chamber that has metal blades that spin like a coffee grinder, and then you form this particulated material, and then you chemically treat, basically to get rid of any unwanted, bugs, and then you put it into the graft. Now, my concern is this. I mentioned earlier on when we talked about allograft, all allografts are demineralized. Some are less demineralized, we call it mineralized allograft. Some are demineralized more, and we call it demineralized. But the bottom line is they need to be demineralized. Why? Without you cannot express the bone morphogenic protein that might be inside. Teeth have certain growth factors embedded, and you have to express it, so you have to demineralize. And when you demineralize teeth, take a look at this picture. We've seen this picture before, haven't we? This looks just like xenograft, or specifically hydroxyapatite, your own bone. Whereas if you do not demineralize in this protocol with this company, I don't know how you can get that, because they're not demineralizing, they're just grinding. And when you grind teeth, I'm sorry, when you put broken pieces of teeth inside bone, they remain as broken pieces of teeth pretty much for a long time. You've seen that because you've done that inadvertently. You broke a tooth and left a root stump. Years later, somebody picks it up. Oh, there's a piece of broken root. Who did that? So this is actually research coming out of Korea with this Vacuosonic. Is a company that I helped and consulted with, and they have some uses in the United States and elsewhere. And this is actually human tooth, and it was demineralized using chemicals and their proprietary technique. And because it's demineralized, it expresses growth factors and it turns into real bone. So just like any other, just like allograft. So who needs it? It's actually a niche market in certain parts of the world where allografts may not be readily available. Then you tell the patient, you just extracted your tooth. You want me to keep this and make this into bone? We have technology for it. I think there's a great niche for that. So our good friend and colleague, Professor Son, who we work together, the inventor of sticky bone, look at his work. He takes this challenging case. The tooth that was taken out was demineralized under vacuum and under high pitch vibration using chemicals. And then he created holes to make it allow progenitor cells to go in. This is osteoconduction material. Drill the hole right through the tooth, a molar. You can still see the shape of a molar, and place the tooth and the implant, the whole tooth, nothing but the tooth plus the implant, into the site and buried it. And look at this beautiful result. Ring block concept, but this works because of the demineralization. If you do that without doing demineralization, that tooth will remain as a tooth forever. So utilization of sticky bone, you can add growth factors to any bone graft material. So these are the 4, 5, if you want to call that, different categories we talked about. Any one of them, we can add autologous fibrin glue. That's what AFG stands for, and that turns into sticky bone. I bring that up because I don't know how many times I was asked, where do you buy sticky bone? Who sells sticky bone? Sticky bone is not a product. Sticky bone is what you manipulate and make chairside by using this modern technology, the biologically enhanced growth factors. So you can take any of these material and turn it into sticky bone like this. These are examples of how sometimes you don't really need to be sophisticated and have layers. Sometimes it's a fairly large defect. I do a 50-50 blend of mineralized allograft and xenograft. What it does, it holds the xenograft particles all over so that it resorbs very, very slowly, allows the implant and the bone to grow in between. So it's a very nice and simple protocol to hold up the bone volume. Ladies and gentlemen, that's why there are so many bone graft materials out there, and I hope that I didn't confuse anybody. I hope this was relatively easy, understood material that you can use in your practices on a daily basis. So my lecture is up, and I will be very happy to answer questions at this time.
Yes, thank you, Dr. Kim. We will be going over the questions that we have received. So the first question will be, do you like osteoplug as bone preservation?
Do I have a reservation?
Oh, no. Let me repeat the question. Do you like osteoplug as bone preservation?
Oh, do I like osteoplug as bone preservation?
Yes.
Okay, I'm sorry, I didn't quite understand that question. Osteoplug. I believe Osteoplug is a brand name, and I hope I'm getting this right. I may be wrong. I think it's a product from a certain company. I believe it's a bone hydroxyapatite particles embedded in quick resorbing collagen dressing. That's my understanding. Here's my thought. In that formula, it's convenient to use, and I really want to make this very, very clear. When salespeople and companies approach clinicians, I don't mind going a little extra mile to make things happen. Yes, of course, a clinician wants to do things easy. I want an easy protocol, of course. But if the easy that I accept is given away for good biological reasoning, I think that's a bad trade. So here's my example. You want to add this into its formula, which is easy. You pick it up and put it in the socket. If that's the price I pay, if that's what I'm willing to get, but what I'm giving away is some of the good proteins, that may not be a fair trade. Why am I saying that? You're putting in collagen dressing into a socket, the body has to resorb that away. That collagen is not the same as the collagen fibrils within bone, not the same thing. Okay, so you're adding unnecessary material simply because easy to manipulate. No. Number two, the particles in there, I believe, if I'm correct, is hydroxyapatite, xenograft type material. Why would you use 100% hydroxyapatite in a socket? I wouldn't. My go-to is allograft. Again, let me reiterate. Using hydroxyapatite, or I'm using it as a very broad term, using a bovine hydroxyapatite sintered, xenograft is popular in Europe, not because it's the best way, because they don't have allografts. So in this country where we have a lot of allografts, readily available, very reasonable pricing, no regulation that hinders us, there's no reason to not use that. So let's not fall these concepts. And that's the whole point of this presentation. I want people to understand the science behind it.
Thank you. The next
Could we go to
question, yes. The next question is, what kind of antibiotics and pain relievers do you prescribe after surgery?
What kind of antibiotics? And antibiotics is case dependent. If it's a so-called clean case, I may even just use antibiotics for 2 or 3 days or even none. If it's a very complicated, compromised case, then you might do 7 to 10 days. Amoxicillin broad spectrum, and that's generally the case. More importantly than the antibiotics is the anti-inflammatory. Anti-inflammatory, we used to have Dolovid and things like that in the past, but today what we have at our discretion is ibuprofen. That's about the only thing we have. We have ketorolac, but that's not appropriate. Only for very, very serious cases. So we tend to like to use ibuprofen, relatively low dose, 600 or so every 6 hours, every 4 to 6 hours, depending on the patient's body weight. And of course, the reason for doing that is to promote anti-inflammatory which actually speeds the healing process. Could we go to the next question? I hope I answered that question. It's a little awkward in the webinar because we don't have direct responses, facial expressions, hands going up. So it's always hard to gauge the audience.
Right. No worries. The next question will be, what bone do you recommend for sinus graft?
For sinus graft, that's an excellent question. If you go back to that example from my 2006 paper, at that time, a lot of people were saying 100% biomass. In fact, we have done that in our residency back in the 90s. We went through this learning process collectively. The whole global dental community went through that. And at that time, that was it. But after reviewing our results, most of us said, this doesn't look right. We need to have some turnover. So let's go to the other extreme. In the periodontal community, demineralized bone allograft has been very commonly used. So a typical periodontist, just like a knee-jerk response, would put demineralized allograft into the sinus. And the results that we have seen, and we have a lot of histology, I think Wallace's work, there's quite a few, NYU Denistano's group has shown that when you look at their histology, we tend to see marrow space, not well condensed bone. We tend to see that sort of histology. So that converted most of us to going to the mineralized. More recently, we're seeing mineralized allograft and demineralized or mineralized cortical, mineralized cancellous combination. This is becoming more and more popular. And as I said, Maxios has these formulas ready-made in a jar, so it's easy. Prior to those, we had to actually open 2 vials and mix it together, so you felt like a cook and a chemist. You used to do that sort of thing all the time. So today, the short answer is, if it's a straightforward sinus, I would mix roughly 30% xenograft and about 70% mineralized allograft. Why xenograft? 2 reasons. Having xenograft holds a volume. Very good reason. Number 2, you can identify the bone graft matter on CTs and PAs and panoramics much more readily as opposed to mineralized allograft, especially when we have these mineralized and demineralized, because demineralized allograft do not show up on radiographs, doctors. You need to understand that. There's no calcium, X-ray beam right goes through. So when you have that, I just want to add a little bit of xenograft for several reasons: holding up the volume, radiographically detectable. So if there is, let's say the sinus perforation and bone starts to spill out, I can identify that. So those are some of the practical reasons. And let me tell you another funny reason. I'm a referral-based surgeon. Okay, if a doctor refers me, can you do a sinus graft and place an implant? Sure, I did. Here you go. Send the patient back. If I use no bone, which is another technique, Professor Son in Korea does that all the time. He just puts CGF, no bone. But if I put allograft only, they call and say, hey, you didn't use bone? Oh, yeah, I did. It becomes an awkward explanation. They kind of imply like, you didn't put bone, but charge the patient that sort of money. So I just want to avoid that. Just, yep, right there. You see the bone? There it is. So putting a little bit of xenograft has that added benefit of communication and so on. So, I say roughly 30%, 70% xenograft, allograft, but there's no formula for that. At this point, I feel like a cocktail bartender. 50-50 is fine. 30-70 makes more intuitive sense, but there's no real science behind this one. Whatever the customer is happy with.
Great, thank you. The next question is, when is corticocancellous allograft most favorable?
Corticocancellous. I take the question to mean the blend of cortical bone and cancellous bone, and I'm assuming it's mineralized. Now, because we really haven't talked about the periodontal regeneration, and when it comes to periodontal regeneration, number one, I choose demineralized, and at that point, corticocancellous doesn't even become an issue. And then we're talking about other enzymes. What sort of enzymes do we use? What sort of membrane do we use to try to grow the bone and the periodontal ligament? So let's shift that out. I'm talking about sockets, sinuses, ridge augmentations. For that purpose, we are talking about allograft that's mineralized, and I'm talking about cortical and cancellous. Why would you use that? I would use that pretty much all the time. Sinuses, sockets, and ridge augmentations. Why? Because if you chose to use cortical and the result isn't good, you can't prove what caused that, but you might think, maybe there was enough growth factors expressed. If I use cancellous only, you might get a lot of collapse because it's not as solid and not as mineralized. That's why you have comfort when you mix the two. Let me interject as to how that history came about. Many, many moons ago, we had a product called Puros. When Puros came into the market, it was allograft, but from Germany. Slightly different protocol than the American allografts. All of a sudden, people liked using it, and so it became a very popular product overnight. And the thing about the Puros is people were sharing information, how would you use it? And because there's a cortical version and the cancellous, which one do you use? And people say, I don't know, I miss half and half. And then the opinion leaders started to give that opinion, and people started to do that. It was very popular where more people were mixing half and half. And soon thereafter, people said, oh, that's a good way to do it. And the first company that said, wait a minute, let's capitalize this and actually put two vials into one was actually BioHorizons. BioHorizons came up with Mineros, and I was on their focus team. I was a consultant for them at that particular time. We said, why not? People are doing that, and there's no logic to not do that. Put it into one vial so consumers don't have to purchase and open two vials. So that became an overnight hit, and then now pretty much everybody seems to have that. And like I said, Maxius has done even better. They put cortical particles, cortical mineralized, and demineralized, and that marries the best of both worlds. I would tend to use that for most of the situation. There's not one case where you have to do that, but not the other. In general, that is the safest way. Just make your life easy. Use that most of the time.
Thank you. The next question is, can you explain one more time why it is important to be demineralized and what the process is to make it demineralized, please?
Very good. The bone formation process, again, I'm probably oversimplifying and not being very scientific. Do apologize for that, but that's who I am. I'm a clinician. I'm not a PhD. Intermembranous bone growth, which is the bone that we are dealing with in clinical dentistry, because we're not dealing with infants. So in that situation, for bone to lay down, if you recruited a bunch of osteoblasts and osteocytes and said, you go to that area, to my socket, and please form bone for me, you have to allow these cells to have a matrix. What I mean by matrix, they have to lay down somewhere and, okay, I'll get to work, I'll lay down calcium, you need to give me something, like a fabric. That is collagen. You need to have collagen fibrils to be able to lay down bone. Where do you see collagen fibrils? Organic matter of bone is literally stuck to collagen fibers. So when you take bone, human bone, and then you put it in acid and take some of the calcium away, you expose collagen fibrils, which is literally, like, no pun intended, skeleton. That's a skeleton of bone, is collagen. So that collagen is needed. Without doing that, you are causing the cells to cause osteoconduction and not osteoinduction. So bone graft by definition has to be demineralized. Now, autologous bone has collagen fibrils exposed because we've crushed them and so forth. Alloplasts do not have that. Xenografts do not have that. That's why bone grows much slower in those categories. Hence, allograft, which has been demineralized, is the best choice. When you demineralize a lot by putting acid for a longer period of time, this is what actually happens in tissue banks. A long piece of the bone from a donor, let's say long bone from the arm, the leg, they take it, they literally put it in a bucket with acid overnight for, whatever that time is. In the morning when the worker comes and picks it up, it becomes rubbery and flexible. how rubbery and flexible determines whether this is mineralized category or demineralized category. But they all demineralize so that the collagens are expressed. So that's the key thing that you need to understand. Without the collagen fibers being available for the cells to sit down and lay down the calcium, we cannot create new bone.
Thank you, Dr. Kim. It seems that is all that we have for tonight.
Great. Thank you very much for this opportunity. I really appreciate this. If you have any questions, any follow-up questions, things don't make sense, there's my email. Contact us. Contact our GDIA people for any other information. And Rebecca, you have some information about other programs?
Yes, I will be making those announcements very shortly. Is there anything else you wanted to add, Dr. Kim?
No, I am good, thank you.
Okay,
I'm
great.
I'm just all those hearts popping up. I've never seen that before.
Hearts?
Yeah, I have a lot of likes popping up.
Oh, I guess everyone's showing their appreciation for your lecture today.
Oh my gosh, now that I said that and sort of force people to do it, there's even more coming up. Lots and lots of.
Thank you, Dr. Kim, for your very valuable share of knowledge today. We thank everyone for joining us for today's session this evening. As we are slowly returning to our offices and workplaces, we hope everyone continues to stay safe and keep the precautionary measures for the safety of everyone's health. Furthermore, we do have some quick announcements. Next Thursday, we will be hosting another free webinar on how to avoid and manage some complications in implant dentistry. Using many clinical situations as examples, the presentation will identify the most common implant complications and will focus on many practical clinical tips. In addition, on Thursday, the week after, July 2nd, we will be offering another free webinar on achieving implant occlusion predictability. This webinar will provide the attendees with insights about predictable and long-lasting implant crowns, fixed hybrids, and overdentures. With that, we ask for your continued interest and support for our upcoming events. Therefore, please register for these webinars at webinar.gdia.com. If you ever miss out on our webinars or ever want to go back for a review, you can get full access to all our GDIA webinars by simply becoming a GDIA member. Please reach out to a GDIA representative at info@gdia.com on how to become a member. We hope you found today's session valuable, and we look forward to your continued participation. Thank you, and we hope you all have a great week.
Good night, everybody.
Good night. Thank you.